the aim of the talk, we will be talking about how omega-3 supplementation can help oxidative stress markers in adult patients. But first, we want to take a few minutes to talk about what we do in our hospital, so every one of you have a more idea of what we are doing here. Okay, so we work in a hospital that is called Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Subirán, which is a third referral public hospital who exclusively attend adult patients and is specialized in attention of complex cases of internal medicine. We are not a very big hospital that have a lot of beds. We have 164 beds, 20 beds on the ER, and 22 beds in the ICU. But our hospital is very specialized in complex surgeries, for example, Whipple's. Last month, we have the first synchronous pancreas kidney transplant, and we want to move forward in other types of transplantation as intestinal transplantation. In Mexico, there is no place that we can have an intestinal transplantation, so it's very hard for patients with type 3 intestinal failure to have a transplant. So we want to move forward in that area. Talking about specifically in the area we're working is the clinical nutrition department. A brief introduction, we work with nutritional attention and with a preventive, also therapeutic input in ambulatory and hospitalized patients. The group is formed by two medical doctors specialized in clinical nutrition, and we have 3 to 5 residents each year. Talking about dietitians, we are 9 dietitians that work all year round, and we have 8 practitioners, 9, 10 practitioners of nutrition. And we arranged to have this year 1 nurse practitioner that is also very helpful with all the infusions of enteral or parenteral nutrition, and 1 physiotherapist that also moved to our group 5 years ago. We do several activities, and this hospital is recognized not only for the clinical attention, but also the research. We are a hospital that do a lot of research. We are the main hospital that do research in the country. So we are a reference hospital, not only for clinical, but also for research. In our area, our main research programs are dysphagia, intestinal failure, of course, and all the medical nutritional therapy, especially now on surgical patients, and how nutrition could help for them. Well, talking about intestinal failure research, that is our main topic. I will only show you a few publication that we have in home parental nutrition, in hospital epidemiology, and then we move forward to the intervention studies and this part. So all our research is focused on how following the nutrition care process will help patients with intestinal failure. For those who are not very familiar in what is the nutrition care process, all the dietitians I know that have this for sure very well known, but patients, when they have intestinal failure, we classify them in type 1, type 2, type intestinal failure, but also screen all patients. So every patient that arrives to the hospital is screened before 24 hours they are admitted. So we can see if they have a nutritional risk of developing malnutrition. After that, we make the nutritional diagnosis, and from that point, we decide if they have total parenteral nutrition or if they are able to have an oral or enteral nutrition, at least some of it. And then we monitoring all the patients with body compositions, indirect calorimetry formulas, or so on. But our research main is in that area. So talking about home parental nutrition, since 20 years ago, we are following all patients with intestinal failure in our hospital and see how long they stay with the parenteral nutrition. In 2015, Dr. Serralde was invited to be part of the SIF Attention Day made by ESPN. And something that is very important for us is since 2022, we have free treatment for our patients. So every patient that is in the hospital can have a total parenteral nutrition by free in their homes. This helps a lot because prior this year, patient must be in the hospital all time. So now it's better for the patient because they can go home and infuse themselves the parenteral nutrition. Talking about the epidemiology of patient with intestinal failure, our first study about it was in 2019 to see the incidence of type 2 and type 3 intestinal failure, and we made an update that is recently published. Just talking about a little bit this last publication, so you can know a little bit our patients that have intestinal failure. Of course, the majority of the patients that are in the hospital with intestinal failure are type 1 intestinal failure. They don't have more than 2 weeks the total parenteral nutrition. And less patients, of course, have type 2 or type 3 intestinal failures. Those patients with type 3 intestinal failure mainly are these patients that doesn't have enough infusion of parenteral nutrition, maybe at home, catheter infections that are every year decrease the amount of patients with catheter infection. So that's good news for us. And these are the causes and physiopathology dividing by the type of intestinal failure of the patient that we receive. So as you can see, of course, in type 3 intestinal failure, the majority of our patients are because of surgical complications. And for example, is widely the range of causes for type 2 intestinal failure. And talking about physiopathology, it's very interesting seeing that motility disorders are mainly the same amount in the 3 types of intestinal failure. And something that we add in this final publication that we made about the epidemiology was about body composition. As I told you before, we also want to see how nutrition impact in these patients with intestinal failure. So we try to divide it in acute intestinal failure, just see how patients with less than 2 weeks of this problem is different from those who has more time, the intestinal failure. So it's not surprising for us, but as you can see, the BMI is quite different. Patients that arrive just with type 1 intestinal failure are overweight, the majority of them. This talk about like our reality in Mexico. Almost 70% of our population has overweight or obesity. So it's not surprising that type 1 intestinal failure patients has this type of BMI. But as soon the disease progress and it cannot be resolved, you can see how the BMI change a lot. I don't know if this is similar to you, but it's around 20, the BMI. And something that is also very interesting is the fat mass and visceral fat mass that also talk about all other comorbidities that could affect the results in intestinal failure. So the main part of the weight that people lose is not only muscle mass, but is fat mass. We thought at the beginning that muscle mass was going to be the main part of the weight that only for us, it was of the weight that they lost. it was a segmental body composition, because this talk about the prognosis of the patient, the mortality, the length of stay of our patients. And something that we didn't realize that will happen was that type 1 patients with intestinal failure tend to have to be more overhydrated than patients with type 2 or type 3 intestinal failure. And of course, in the part of phase angle, that it talked about how our cells in our body are, if they are healthy enough to be in some treatment or not. We also see that patient with type 1 intestinal failure has less phase angle. That is something that is worth to know, because patients with less than 4 phase angle, it is well recognized that they will have a worse prognosis at the end. So that also match with something that we see in this research, that patients with type 1 intestinal failure have more rate of death than patients with type 2 or type 3 intestinal failure. So this was very interesting. The article is already published, so here is the reference. You can see it with more detail. But I think something that is very useful to know, because we all time think about patients with type 2 or type 3 intestinal failure, because we are more worried about them because they took more time with the problem. But patients with type 1 intestinal failure sometimes are not well seen in that area, and maybe they will not have afterwards the need of having parenteral nutrition, but they will have the bad results of living with less fat mass, living with less muscle mass. So it's quite interesting seeing what happening with this type of patients. And something that also we added in that part was seeing what we are doing with the parenteral nutrition. If the patient have more requirements or less requirements of infusion of enteral or parenteral nutrition. In this case, all patients, this resting energy expenditure was measured when patient has exclusively parenteral nutrition. So also it was quite interesting seeing, it doesn't matter if they have type 1 or type 2 or type 3 intestinal failure, the requirements are almost the same, like 1,500 calories. But what was interesting was that the protein was the main macronutrient that patients with type 2 and type 3 intestinal failure use. This talk about that probably if we don't adjust well the parenteral nutrition, all the energy that we are given to them, they will use the protein as energy and not for preserve the muscle mass. So this was also quite interesting to see. And then, and now I promise that I jump in the main topic, is talking about this pilot study that we performed. It talked about how patients with type 2 intestinal failure react in an acute dose of omega-3, because we have a lot of studies that talk about how omega-3 can help a patient with type 3 intestinal failure, but there's few studies that talk about what happens in patients in the hospital and if we supplement this type of lipids. So again, I know that maybe part of you know a lot about omega-3 and this part, but I will make a short introduction of how nutrition works. So for those that have no part of how parenteral nutrition is prescribed, us as registered dietitians, we set the goals of our patients. We see with indirect calorimetry or with equations how much calories, how much protein people will need. And based on this, we can set the amount of parenteral nutrition that we give to our patients based on the ESPEN or ASPEN guidelines. And part of the consequences of prolonged parenteral nutrition feeding is that lipid emulsions can affect our liver. So it is well known that high doses of lipids could affect our liver, also because it is the majority of parenteral nutrition infused with soy oil. The amount of omega-6 is higher than we expected, and this also can lead to hyperesterolemia that is related to liver toxicity for some patients. Also, lipid emulsions that have exclusively of soy oil have less alpha tocopherol than other type of emulsions. So this could also lead to liver damage. For those also that maybe don't know, the lipid emulsion have been changing through the time. So when parenteral nutrition started, the first generation was exclusively of soy oil, and the relationship of omega-6 and omega-3 was quite higher. Of course, more amount of omega-6 and less of omega-3. So research start and see this problem and start the development of different type of lipid emulsions. So nowadays we have several type of lipid emulsions. In our hospital, for example, we only use this type of emulsions that is based on oleic oil, that is not that high in omega-6, but also have omega-9 that also is well known that could help patients this type of problems of liver lipid accumulation, and afterwards we want to see what happens if we add fish oil. Unfortunately, in Mexico, it's quite expensive having this type of lipid emulsion that is the complex of or the different type of lipids. So sometimes it's easier and cheaper for us only add to our parenteral nutrition exclusively fish oil. So that's the reason we decide to do the research in high doses of omega-3, given exclusively beside the olive oil, the fish oil, and not to choose the smooth lipid that is the more common mixture. Also, we know that for long term, it's even it's expensive to buy omega-3 lipid emulsions. The cost benefits in a hospital is quite good. So we wanted to see if in an acute phase, this addition of omega-3 could help to reduce also our hospital costs in the future. We didn't do this research in this publication, but it's something that we want to work afterwards. So also, why is this so important? So consequences of prolonged intestinal failure, as you also know, could affect the intestinal barrier, and this can lead to translocation of endotoxins, can increase the amount of inflammatory cytokines, have more reactive species and less viable sterol transporters. If we have this problem of intestinal failure and we add lipid emulsions that are higher in omega-6, that's the reason some researchers found that intestinal failure associated liver disease can happen. So this is something we want to prevent in our patients, because also it's expensive to have more patients with this type of complication that try to prevent it with the part of the nutrition. So our aim, or what we wanted to do, is adding this high dose of omega-3 will help to reduce this translocation of lipopolysaccharide and other endotoxins that could affect in the enterocytes, and with this reduce the amount of inflammation, and of course, the part of oxidative stress. So what we do was a pilot study, what was a randomizable blind clinical trial. And the reason of this was because we didn't found in that time enough literature to do a wider research. So what we decided was to start from the beginning, doing a pilot study, see what happened. So we follow our patients that were already classified as type 2 intestinal failure patients who exclusively had total parenteral nutrition at least 28 days. And it is very important to say that exclusively because as soon as you start enteral or oral nutrition, enterocyte could be healthier. So we wanted to have only the parenteral nutrition infusion to see if this infusion of omega-3 could help. So as soon as these 28 days finish, we invite our patients and randomly assign them to continue with the usual parenteral nutrition or the parenteral nutrition group that was added with omega-3. And the dose that we choose to give to our patient was from 0.1 to 0.2 grams per kilogram per day. These are the inclusion criteria that I already mentioned them, but exclusion criteria was a patient that were pregnant, for women that were pregnant or breastfeeding. It's very rare, but we have 2 cases of patients that has allergy to fish. So we decided to avoid any complications, so we didn't invite them. A patient with immunosuppressive drugs or chronic renal or hepatic failure or with an active cancer, because we wanted to see if the oxidative stress markers could be changed, and if they have this type of diseases, it will be harder to see any changes. So we assess for eligibility 734 patients. Sadly, a lot of patients were lost because several reasons. It is quite hard for us to find patients that only have parenteral nutrition more than 28 days. So that was the main reason of losing patients. A lot of patients around 15 days, 20 days, we try to give them some oral or enteral infusions. So it is quite hard to find patients that exclusively have total parenteral nutrition longer than a month. And you can see also cancer is one of the main causes that we exclude patients. But at the end, we have 20 patients, 10 of the controls, 10 for the intervention. And luckily for us, all patients finished in the study. So we analyzed the 10 of them. Just for you to know the causes and physiopathology of the intestinal failure. Disorder, motility disorders were the main cause for intervention group, and fistulas for the control group. Even we didn't find significance different. It was in this case. And as I told you before, surgical complication is sometimes the main cause of the intestinal failure. Also, we didn't find difference in admission characteristics. In this manner is good because it talks about that our groups are quite dissimilar and can be compared from each other. And talking about age and weight, all patients are around 45, 52 years, that we also consider is a young population. Sometimes we expect a patient don't have this type of problems being in these ages, but we find this type of years. And talking about biochemical parameters, even patients arrive in in somehow stable. There are some markers that are quite higher. And also talking about the composition of parenteral nutrition, we didn't find differences, but what I want to show you is the amount of omega-3 that we give per body weight. As I told you before, it is well known that 0.1 to 0.2 is our recommended dose of omega-3. Our patients receive around 0.18 of omega-3, so it was good amount for it. So talking about oxidative stress variables, just for a glance, we wanted to know if we made the analysis just talking about these oxidative stress variables, if there was a difference. And we couldn't find a lot of differences in some point because it was a short sample size, but also we were wondering what happened in the reality, because if we think about a variable and we want to see, for example, ORAC, that is one of our variables, we can say, well, maybe this oxidative stress variable can be affected, but not only because patient is the intestinal failure, or it helps because only of the omega-3. We wanted to see like an overall idea. So we made an analysis considering different variables. That is the reality. Patients have different type of biochemical parameters, have different ages. So what we made here was a general model considering other covariables that are highly related to high oxidative stress in patients with intestinal failure. So we took in account age, sex, direct bilirubin, indirect, alkaline phosphatase, PCR, lipopolysaccharide, and other oxidative stress variables, and see which of these variables affect the most for having high malonyl. That was the main goal for our project. So at the end, we found that having a high dose of omega-3, that is to reduce almost in 1 point the amount of MDA. So that was quite good. Also, HDL, having higher amounts of HDL could benefit patient to have less MDA. And of course, the H and ALT have a worse outcome and increase the amount of MDA. So in other biochemical parameters in our patients, we found some differences. Some of these differences not like very uncommon, for example, but what we were very excited about was finding out about lipopolysaccharides, because this talk about also how gut microbiota is affected by the supplementation of omega-3. So this is why quite promising, seeing that in intestinal failure patient that exclusively are fed with total parenteral nutrition, is also very hard to improve the gut microbiota. Enteral stimuli is well known to help, but in these cases that we cannot feed the patients, it's quite promising seeing that something that can be infused in a parenteral way could positively affect in this part. So it was quite exciting seeing that lipopolysaccharide was reduced in the intervention group. And just as conclusion, we know that this project is a pilot one that maybe is not a high sample size, but we were able to demonstrate that the addition of a therapeutic dose of omega-3 can improve some of the outcomes in an acute period. And also this result encouraged us to do more research about it. And we are certain that one of the main causes that helped in finding this result was the changes in the ratio of omega-6, omega-3. As I told you before, some of the limitation, we know is the small sample size. We have the bad fortune that COVID-19 was around the corner when we started our protocol. So it was quite hard to find the ideal conditions for doing this study. We stopped the study actually for a year and a half because our hospital was for full attention of COVID-19 patients. So all our patients with intestinal failure were referred to other hospitals to be treated. So we have to stop a little bit in that area. And also one of the limitation was that the majority of the oxidative stress marker that we know about it, they have a short term of life. So we struggle in the pandemic to measure in the precise moment all the variables. So we hope if we continue in this research, we can do a little bit better in this area and have better outcomes at the end. So what next? In matter of this research, we are now doing some research about lipidomic. Dr. Natalia Vasquez is our expert that do lipidomics in our hospital. So she's working now with our samples, and we want to see if part of these results could also be related in how lipidomic function with different lipid intravenous emulsions. So we hope to soon have some results about this area as soon as she finished to process all the samples. And that will be all. Thank you for having me.
Thank you so much for your talk. Are there questions? I have like 1,000 questions if other folks don't have questions. And I don't know if there's anyone in the conference room that has questions, feel free to ask. Well, I mean, I hear that you say that your sample size was a limitation, but I actually think that's extremely impressive. As you probably know, in intestinal failure, we almost never get a prospected blinded study. And your selection criteria were really very rigorous so that you had no oral or enteral nutrition. I know that the glucose and triglycerides weren't significant, but they still trended towards lower. What do you make of that? That's really interesting, I think.
Yeah, we were expecting better results also in glucose and triglycerides, but as you said, unfortunately, this significantly is not. But we think that also the inflammation of these patients could affect it. So patients that are 24-hour infusion of total parenteral nutrition could be affected glucose and triglycerides. In our hospital, we try to give them parenteral nutrition through 24 hours. I know that sometimes in other hospitals, as soon as the patient is more stable, they switch it to 16 hours or 12 hours. We only do that in patients that go home with parenteral nutrition. So we switch it from 24 hours to 12 hours so they can be free at home at least a few hours without the infusion. But in the hospital, in order to have things more restricted and less infections and things like that, we have the infusion 24 hours. So that's also the reason glucose and triglycerides can be affected.
I see, that makes sense. Can you go back to your slide with the consort diagram? So at the beginning of the study, there were 734 patients, is that right?
Yes.
And so tell me, these are all adults that get referred to Mexico City, and they're all type 2 or 3, or the first group, this 734 were all type 2 or 3 intestinal failure patients, correct?
Yes, what we do for this protocol is, as I told you, this is a third referral hospital. So we receive all the cases that cannot be resolved in other hospitals. So that's the reason also we have high numbers of intestinal failure patients rather than other hospitals. We follow patients that had either 1, 2, or 3 intestinal failure. These are patients that have more, at least than 2 weeks of parenteral nutrition. So they are in this like in the middle of being type 1/type 2 intestinal failure. That's also the reason this is the high number.
I see. And so if they are, if it's anticipated somebody would only need TPN for maybe less than 2 weeks, do they stay at a local hospital? So like someone from Guadalajara would not come down to Mexico City unless it's anticipated they're looking more like a 2 or a 3. Is that?
No, what happening here is sometimes patients, well, if they arrive in here and start the treatment here, we start since day 0 until they are discharged.
Okay.
We have some patients that are from other hospitals that they are not only 1, 2 weeks, they are in the other hospital maybe 3 months, and they couldn't solve the problem, so they are transferred to our hospital.
Okay, that makes sense. And so the dose of omega,
there are also
it's frozen. It froze a little bit. So can you say it one more time?
Oh yeah. So we have some cases that patients from other hospitals that have surgeries that couldn't have a good prognosis. At the end, they have total parenteral nutrition for more than 1, 2 months, or even worse, there are other hospitals that they don't have the resources to infuse parenteral nutrition. So if they expect that the patient will stay without the oral or enteral supplementation, they send them to us to give them that parenteral nutrition.
I see. And so in the hospital, the 0.1 to 0.2 grams per kilo per day of omega-3, was that a bag of Omegavan that was then split and given, or okay?
Yeah, what we wanted to do is, was to give the full amount of Omegavan. So all patients had, that's the reason they have like this range of 0.1, 0.2. So we give the whole 10 grams of omega-3 through Omegavan. So if, for example, a patient needs 50 grams of lipid per day, we have 10 of them of Omegavan, and the other part of the 40 of oleic oil.
Got it. Sorry, if other people have questions, please speak up. I have like a bunch of questions otherwise. And do we have our medical students? Did any medical students get to join today? I think there were some non-GI folks probably in the room. Maybe not. Okay. So it seems like the majority of your patients that end up on home parenteral nutrition have chronic motility disorders or some surgical cases, but that mimics, our adult experience also. It's the similar epidemiology. So I heard you say that as of 2022, home parenteral nutrition became free. Can you explain that a little bit more? So is it that the state or the country covers the service so people can leave the hospital now? Or can you tell us a little more about that?
Let me go. Mexican treatment of nutrition is quite different than in the US. We have private hospitals, we have public hospitals as every country, but since people that are in public hospitals prior this year, For example, if we have a patient, they were classified according to their incomes, to see how much they can pay for the treatment. So for example, people that could not afford anything, they paid like very symbolic amount of treatment, and some other patients pay more. And patients who have a social security usually are not patients that we receive, because if they have social security, they have hospitals that attend this type of patients. Our hospital mainly attend people who doesn't have any resources of private or social security. Since 2022, what we do in our hospital is that all patients that doesn't have this, they will not have to pay anything for anything in the hospital. So they don't pay for parenteral nutrition, they don't pay for the consultations. So the treatment is free. This helps us because in this case, we can attend our patients with our treatments. Before this, we had to find a way for our patient with intestinal failure, if we want them to go home, to see if a relative or someone can introduce them to social security. So the hospitals with social security can give them the parenteral nutrition. Otherwise, they will have to stay in our hospital for months.
Definitely, right?
We have 2 cases that they were more than a year in the hospital, the patient, because they couldn't afford going out and pay the parenteral nutrition. Nowadays, the cost of parenteral nutrition, if people want to pay it privately, is around like $700, something like that. But $700 to $900. So it's quite expensive for someone to spend every day. Like, even if we wanted to give them only 3 days or 4 days, parental nutrition is quite expensive to spend more than $500 for being nourished.
Yeah, of course. Wow, that's incredible. And was it a hospital-based policy change, or was it a state-based? Like, how did this change in 2022?
It was for the government.
Okay.
So in the change of the government, the government wanted to give all people or the majority of the people free treatment. So we move in this manner to give them. There, of course, there are some difficulties in the middle to try to arrange this, but we are trying to manage this part.
That's so cool. And so maybe my last question around that, it also sort of related to health policy, would be for the people who do get private insurance, or who go to private hospitals, do they have a separate referral center? Because it sounds like your center is the center that focuses on this subspecialty care. Is there like a separate system with subspecialty care for private hospital, or would they still come to your hospital because you have the transplant center, you have the TPN? Yeah.
If they have a private attention, they can go to private hospitals, and there are some doctors that are specialized in this area. I'm not quite sure if there's a place that has like the same as us for a private hospital. We know that in private hospitals, for example, some of our doctors also work in private settings. So sometimes they see patients in a private setting, and sometimes they see in here. But with this full, like the whole like treatment of having nurses, because I didn't mention it because it wasn't like full part of the talk, but we have we create like a clinic for home parental nutrition. So in this clinic, we are involved several specialties. For us, of course, in nutrition field is for patients that are with parenteral nutrition, or we we see our patient, for example, with short bowel syndrome, if they have to infuse only fluids, also we manage that part. But we have specialized nurses that give training to the patient and their families. So the rate of infection, of catheter infection can be reduced. So the nurses give this training to the patients. Every week, patient has to come to our hospital to assess if the catheter is okay, to see if they have a lab test, how are the biochemical parameters, if we have to make some changes in the parenteral nutrition and function, make them, and also we have a gastroenterology area that if patient has like short bowel syndrome or something like that, they can also receive these patients. And it is a very huge effort to have different specialties. So as far as we know, we are the only hospital of adult patients that do this in private settings. Maybe they are well communicate between each other, but it's not like a clinic person.
Yeah, not a true multidisciplinary clinic.
Mhm.
Okay, and the last question, if somebody's liver does fail, is that also like, is liver transplant or end-stage liver disease in adults managed at your center also, or is there another referral hospital that people go to if they have that mix of TPN associated or intestinal failure associated liver disease?
Only liver transplantation is in here. O sea, es aquí, o sea, si necesitan trasplante hepático los pacientes. Yes. Yes, if it's only liver transplantation, yes. But fortunately, we haven't had this.
Yeah, that's great. Wonderful. Does anybody else have questions? Well, if nobody else has questions, I wanted to just thank you both again so much for sharing your research, sharing your time, welcoming our division to your hospital virtually, and for everything that you've done for allowing us to observe your clinic in a few weeks. Maybe one day some of our faculty or our fellows could also join, if as long as I don't mess things up and I'm not too much of a pain, hopefully I can bring a fellow or another co-faculty one day. But again, thank you so much for your time. Really appreciate it.
No, thank you, of course, for having us and considering us for being with you, because we know that also this type of lecture are very helpful for everyone to know what happening in other parts of the country, like encourage us to see that we are not like alone in this path.
It's so funny. The problems you have are the same problems we have, right? You're like 30% have motility problems. The catheter is falling off. The dressing is bad. They get eclampsia. Their liver fails. All the same problems. So, yeah. Thank you so much again, Nancy. Thanks so much for everything. Also,
Thank you, guys.
bye. Take care.
Bye.
Bye.
Bye. See you soon.
See you soon. Bye.